DREDF, Healthcare Stories. Diane Collins is being interviewed in an office at Access Living in Chicago, Illinois.
Good morning. My name is Diane Collins, and I'm a geriatrician, retired on disability here in Chicago. I've spent my career as a physician taking care of South Side Chicago veterans. Part of my training that was hospital-based in my early career was the initial first 5 years, where I had more extensive experience with the hospital setting and the way people actually transition to becoming inpatient and the way we discharge them back into their environment. That experience has given me great concern and caused me to rethink on a professional level what it is we accomplish when we treat patients as commodities rather than as human beings with dignity. One of my perspectives in my 22-year experience is collegial, and I'm concerned about the contribution that medical professionals make towards regarding disabled people as burdensome and as requiring more intensive medical use than they deserve. Now let me try to put that another way. Working in the hospital setting or even in a hospital clinic, there are productivity issues. We are assigned 15-minute intervals to see patients. I've noticed in my practice of medicine that many of my colleagues will pre-screen the day's appointments and note that somebody's coming in a wheelchair, somebody's coming who's blind with an assistant, and that starts their day off with great stress, because that means that if they were to give that disabled person his or her primary preventative interventions during that visit, it's going to consume 45 minutes to an hour versus the 15 minutes that we could give able-bodied patients, and that's in scary quotes. And the tension is then transmitted to the nurses, to the clerks, to everybody who supports that visit, because it sets a tone that's negative. The system, in my opinion, is set up to discourage a practitioner's interest in a disabled patient. Because in order for me to understand the complexity as a physician of a patient who has disabilities, which may not be the reason they're in clinic that day, but I still have a mandate to document their history and their condition, which can be time-consuming and difficult to ascertain for more than one reason. So frequently shortcuts are made. I was recently hospitalized, and I try my best not to let my caregivers know that I'm a physician, because I'm moreover an observer. And during my hospitalization, it was evident that I had a disability. I'm a polio survivor, and I also had a traumatic spinal cord injury that left me with cervical myelopathy, which means I have a balance disorder and a gait disorder and chronic pain. And this happened in a fall in my workplace at my hospital. Nonetheless, when I was hospitalized, I did not receive the attention or the interest to my disability. I was simply treated for the exacerbation that I was there for, which means I got weaker and I got worse, and I had way more pain than I should under most circumstances that are attended by capable professionals. And I think when this happens to persons with disability who don't understand hospital routines and who aren't given to understand hospital routines, it becomes disorienting and assaultive and inconsiderate. And I'd like to sensitize medical professionals towards a clearer understanding of the intrinsic dignity of a disabled person, but all people in that regard. If I could speak to hospital administrators and policymakers who are not on the forefront of delivering health care to a variety of able-bodied and disabled people, I would first ask them to consider the equipment. The hospital exam table is very high. I'm challenged by it because of my height, without regard to the fact that I have a balance disorder and multiple joint issues. I can tell you a story as a physician that I had a very tall patient who had a prosthetic leg, and he could sit on the bed without any adjustment. That wasn't the problem. The problem was he couldn't orient himself without assistance to sit on the bed. And he was wearing his artificial limb. The bed was as high as his hips were, but I'm kind of beneath the two of them. And actually, that gentleman and his prosthetic leg, he stepped on my foot. He didn't feel a thing. I felt the most excruciating pain that I've ever felt in consciousness. And he couldn't move fast enough to get off my foot. And I incurred a broken bone in my foot for that. And the reason was the ergonomics and the lack of ergonomics, I should say, in that exam room, and the fact that the physician, who is encumbered by time constraints, is now required to physically assist beyond your physical capacity a patient who cannot orient himself in the posture that you need him to be in order to examine him. And I've had multiple experience with having to help people, patients, get up on that table or get down off that table. And generally speaking, it's a daily grind, and it adds to the attitudes that professionals develop about caring for people. And this is not just the disabled, this is the elderly, this is the obese, this is any person who doesn't maneuver on a standard, which most of us don't, that would allow him or her to get access to medical care. So I think it's more important that even as we think of what we say to policymakers, that we expand the concept more towards universal design, because it would benefit the workers. It certainly would have benefited me. I've had lots of muscle strains and injuries as a disabled physician trying to do a job to support health care for everybody. And I think policymakers must be more aware of this fact. In the course of being assaulted with 35 patients a day, if you had to lift 35 patients a day, you want to choose another 35 patients that you don't have to lift. So I think it would improve that dynamic, that relationship, that doctor-patient trust issue, if the environment could be made conducive to everybody who had grown into a limitation or developed a limitation. The patient who needs physical assistance because of the limitations, the functional limitations of that exam room, is now a burden. And we truncate the visit, we shorten the visit, and make our objectives across 6 visits rather than across 1. And that means whatever was going wrong, we didn't find out during the first visit. And by the 6th visit, it's time to put that person in the hospital. A lot of physicians, I've noticed, and nurse practitioners, tend to look for a reason to hospitalize a person, a disabled person, even at the first visit, because there, the doctors who are working in the hospital will have more time to sort out the myriad problems. So the attitude that physicians develop and role model that is now pervasive becomes so ineffective from a cost basis and from a quality of care basis, because in order to deal with this patient, instead of thinking how to keep them in their home and address their issues or express supportive care in some other way or perform preventative screening, which may be indicated, Now your mindset is, I got to find a reason to put this person in the hospital because then I can see my next patient. And then it becomes the cycle over and over. If you're a 28-year-old and you're going to Bolivia and all you need are some vaccines, I can get that done in 15 minutes. And if I had 35 of you, I could end up on time and not totally exhausted, deeply resentful, and compensated very well for my effort. But that is an idealized situation that frequently doesn't exist in my experience and in the practice of medicine in Chicago. You don't get idealized 15-minute healthy people who just need a shot or a pill. You get people who have social challenges. You get people who have financial challenges. You get people who've been damaged by neglect for various and sundry reasons. And in my desire as a physician to comfort always, I find myself stretched in my capacities with very little help from the health systems that organize to provide health care. A solution to the fragmented care that the disabled, the elderly, and the poor receive as emanating from a patient-centered medical home, which by definition would comprise multidisciplinary teams to address issues that affect the welfare of that particular population. If disabled patients, elderly patients, obese patients could choose a place to be that would coordinate all of their care and be responsive to them individually on a day-to-day basis. And I think that's the best model for healthcare delivery. It's not the hospital setting. It is the outpatient setting where relationships develop and the medically relevant history of the patient is known and discussed in multidisciplinary team meetings. So planning can occur, resource allocation can occur, intervention when appropriate can occur, end-of-life conversations can take place. Recruit the disabled medical professional to teach, train, and serve. That would be my banner.
Healthcare Stories. Made possible with generous support from the Manuel D. and Rhoda Mayerson Foundation. Diane Collins was interviewed at Access Living Chicago, July 2011. For more information, visit the Disability Rights, Education, and Defense Fund website, dredf.org/healthcare-stories. This work is licensed under a Creative Commons Attribution Non-Commercial Share Alike 3.0 Unported license.